Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. Finally, our wait is over, and the day which is we are waiting since from the many days, that is the AIMS Norcet prelims exam, is about to happen tomorrow. So I hope every one of you have good health conditions and already done with your revisions. Students, just one step we are behind. Just we need to take one step ahead to get land into our dream job, right? So that is tomorrow AIMS Norcet prelims exam is there, and I hope everyone, you people, have done your best of the best revisions. And as a master nursing classes, as your master and as your Norcet mentor and guide, Mr. Nagaraj sir given all the possible shots and all the possible content which was necessary for your prelims exam and the mains exam as well. Students, just believe in you. You are not only just prepared for the mains, you are already fit for the cracking the. You are not only prepared for the prelims, you are already fit for cracking the mains exam also. So just you have to believe in yourself. Everything is possible. Just self-belief is important now. Definitely our entire team and your master, Mr. Nagaraj sir, will pray in a God that the result will be your side. Yes, just you have to believe in yourself. Okay, so take a blessing from your parents and move on. Everything is possible, right? So with this powerful motivational line, that the word I am impossible, just the word impossible itself, it is saying now it is I am possible. Why? Because I prepared for this. Why? Because I have spent a lot of the time in my preparation, and finally the day came, and I am going to just land into a war zone, and I am going to symbolize as a victory, right? So yes, it is the time to show the victory. Yes, I hope every one of you are preparing, like already prepared, and every one of you are in journey towards your exam center. Okay, who all are traveling far away, so please start your journey as soon as possible and be in your exam center at least 1 hour before the given time. Okay, so yes, I hope everything is going well now. Okay, don't be in any confusion, be confident. Whatever the thing you have studied already. Okay, so just in the today's session I am going to share those golden points that will reflect on your exam screen, okay, in the tomorrow's exam. Okay, yes, so we will give our best content in the today's session as well, and entire team and your master Mr. Nagaraj sir also wishing you all the best for your tomorrow's exam. Okay, so be confident and be hydrated and be anxiety free. Talk with your friends. Okay, don't avoid the syllabus. Okay, just talk casually with your friends and share some happy moments with your friends. Okay, so you also be happy and make your friends also be happy. Okay, don't over stress about anything. Just be cool, calm, relaxed, and peace. Let's begin the exam in the tomorrow only. Okay, so just be cool, calm, relax, right? So if you have worked hard, means definitely luck will be your side. Luck will also support those people who have worked hard. Okay, so without hard work, the luck will also not support. Okay, so yes, you are the people, you have worked hard since from the 2 months, 1 month, 3 months, 6 months, 1 year, 2 year. Yes, no matter whether you have worked from the last 2 year or the 1 month. Yes, you have worked, means definitely luck will be yours. So believe in you, everything is possible, right? So without wasting the time, the today's session is begin here, and here comes the first question in front of you all. So please do read the question carefully, completely, and try to give the best answer. Yes, what is the primary cause of the RH incompatibility during the pregnancy? What happens in the RH incompatibility during the pregnancy? Yes, what is the primary cause? Why the RH incompatibility is happening during the pregnancy? Option A, ABO blood group mismatch. Beta, it is not due to the ABO blood group mismatch. ABO blood group is mismatching, means we call this one as the ABO incompatibility. It is not RH incompatibility. I am eliminating the option A, right? Then comes to the option B, RH positive fetus and RH negative mother. Option C, RH negative fetus and RH positive mother. And option D, inherited clotting disorders. Yes, beta, RH incompatibility happens due to the Rh negative mother and Rh positive fetus. Okay, so please remember NM negative mother, FP positive fetus. Okay, so negative mother, positive fetus, which will make the Rh to get incompatible. How, sir? Yes, let me quickly explain the actual process, what happening behind this one. Okay, so answer B goes to the correct answer. NM Rh negative mother and FP, that is the positive fetus is Rh positive. Okay, so the very important thing, right? So how the Rh incompatibility is happening? Understand the process. It is very simple. Okay, so here is the a father who is Rh positive. Okay, and here is the mother who is Rh negative. Right. So look at the entire body of the father. All the Rh positive blood group is there. Right. And look at the and mother body. All the Rh negative blood group is there. Okay, and in the mother womb, in the uterus, there is a baby which is having the Rh positive blood group, right? So during the time of the delivery, when means during the time of the delivery, when this baby started to comes out, that time, due to the some entry of the fetal blood into the maternal circulation, that time Rh positive blood of the fetus will go into the mother. So this fetus will comes out. This fetus will comes out. Nothing will happen to the first fetus. Okay. So after delivery, in the mother, what happens? In the mother, the antibodies will start to develop against the Rh positive blood group. When this mother second time get pregnant, that time these antibodies against the Rh positive fetus, okay, it will start to cross the placenta and this will comes into the fetus and it will destroy the fetal blood. So now the baby is having the Rh positive blood group, and against the Rh positive blood group, the antibodies which is coming from the mother means a baby's blood will start to destroy. Okay, so that is what you call as the very important hemolysis in fetus due to Rh incompatibility. Okay, due to Rh incompatibility. But hemolysis is happening. Consider the blood vessels, the blood cells are destroying. You know, the most abundant fluid which is present in the body is the intracellular fluid. Okay, so almost all the fluid is present inside the cell. Okay, so now this particular cell is getting started to damage. So the fluid which was there in the cell which will comes out. Okay, so fluid which is there inside the cell which will started to comes out, and the entire fetus will fill with the fluid. We call this one as the hydrops fetalis. Hydrops means hydro means water. Okay, hydrops fetalis. Okay, so this particular Rh incompatibility having the complication of the hydrops fetalis, right? The hemolysis are happening means all the mature blood cells are started to damage. So the fetal bone marrow will start to produce immature blood cells. Okay, so fetal bone marrow start to produce the immature blood cells. Okay, so that may causes the fetus to land into the excessive accumulation of the immature blood cells in the fetal body. That is what we call as the erythroblastosis fetalis. Erythro means red blood cell, blasto means immature red blood cell fetalis. Okay, so that is what we call as the erythroblastosis fetalis. Means inside the fetus there is excessive accumulation of the immature blood cells, right? So these are the two very important components or the word associated with the Rh incompatibility. One is the erythroblastosis fetalis. Why? Because the hemolysis is happening, all the mature blood cells are destroying, and all the mature blood cells are destroying means bone marrow overcompensating and producing the excessive red blood cells which are immature. So excessive production of the red blood cells that is immature inside the fetalis, we call that one as the erythroblastosis fetalis. And due to the damage of the cells, all the fluid will leak into the body. So that is what we call the accumulation of the excessive water in the body of the fetalis. That is the hydrops fetalis, right? So whether anything happens to first baby in the Rh incompatibility, nothing will happen to the first baby. First baby will come out aram se, it will comes. So second baby, again it is a mother is conceiving. Okay, so mother is conceiving, and in the second baby there is a production of the reaction will be there between the Rh positive blood group of the baby and the Rh positive antibodies which is produced in the mother. Okay, so that is what we call the Rh incompatibility. Please do remember. Okay, let's begin the golden point here. For the golden points for the Rh incompatibility, we will be studying the concept that is very cool, calm, and relaxed concept today. Okay, so please be connected. Okay, so the father will be Rh positive and mother will be Rh negative. Due to the carrying of this blood group in the fetus, if the fetus will be Rh positive, means in the mother there is Rh negative blood group and in the fetus there is Rh positive blood groups. Okay, so this Rh positive antigen from the fetus, it will go into the mother during the process of delivery, during the process of the labor. So this Rh positive blood group from the baby will enter into the Rh negative blood group of the mother circulation. Now the mother will start to produce the antibody against this particular Rh positive blood group. Okay, and this first fetus will comes out when she will be pregnant for the second time or the next time. That time the Rh mother will be having the antibody against the Rh positive blood, right? So that time that antibodies will cross the placenta, which will cause the hemolysis, that will cause the hydrops fetalis and the erythroblastosis fetalis. I hope the concept is clear on the this particular Rh incompatibility. Okay, so next, effect on the first baby. No effect. Nothing will happen to the first baby. Nothing. First baby will come out normally. Okay, so effect on the second baby. Effect on the second baby, it will cause the hemolysis. Okay, that may lands into the hydrops fetalis and the erythroblastosis fetalis. Okay. Very important. Please do remember erythroblastosis fetalis. Hope it is clear to every one of you, right? So the next question is here. Please do read the question carefully, completely, and try to be give the best answer. Okay. So when is RhoGAM, that is the RHOD immunoglobulin, typically administered during the pregnancy? Option A, only after the birth. Option B, at the 12 weeks and again at the 30th week. Option C, at 28 week and within the 72 hours after the delivery. And option D is the at 20 weeks and during the labor. Beta, the answer goes to the at 28 week of the gestation and within 72 hours of the delivery, we need to give them a very important injection NTD or the RhoGAM. But now the National Health Mission NHM news, according to the news circular, antenatal administration of the RhoGAM is not recommended. Okay, so they are telling if the mother is negative and the father is positive, or in case the mother is negative and the fetal after the delivery, we will take the cord blood sample, umbilical cord blood sample, and we will assess for the blood grouping and typing of the baby, where if we are finding that the mother is negative, the fetus is positive, means that time we will give the RhoGAM or the NTD injection within 72 hours of the delivery. So the best answer is the within 72 hours of the delivery is the single best answer. Okay, please do remember, very important question. Okay, so don't forget, during the pregnancy 28 weeks we will give, and after the delivery within 72 hours we will give, the very important one. Okay, so please do remember. But now the NHM is not recommending during the pregnancy. Now the NHM is only recommending to give it is after 72 hours. But still we need to remember the those both. Okay, if you are getting both in the option, please choose the one best answer, that is the within 72 hours after the delivery we will give the anti-D injection or the RhoGAM injection. Okay, so very important, keep in your mind. Okay, so how it will help, whether it will treat incompatibility or whether it will prevent the incompatibility. But is better, this is to give it is given to prevent the incompatibility. How it will be given to prevent incompatibility, I told. So when the first baby will comes out, that time this baby will leave some positive antibodies in the mother. Okay, and now after the delivery, this mother have started to produce this particular antibody. Okay, so if you are giving the RhoGAM injection in this mother immediately after the delivery or within 72 hours after the delivery, Okay, so it will prevent of the formation of this antibody. These antibodies will not be formed here against the Rh positive blood group. These antibodies are not forming means in the second pregnancy also there is no antibody to destroy the fetal blood cells. There is no antibody to destroy the fetal blood cells means the fetus is hemolysis not happening, hydrops fetal is not happening, and the erythroblastosis fetal is not happening. Please do remember. Okay, so it is given not to treat, it is given to prevent the Rh incompatibility. A RhoGAM injection is given to prevent or as a prophylactic for the prevention of the Rh incompatibility. So please do remember. Okay, so it will prevent the production of the antibody in the mother body after the delivery. That is the very important point you have to keep in your mind. Okay, hope it is clear to every one of you, right? So how to prevent the Rh incompatibility? I told give RhoGAM injection or the RHD injection to mother at the 28 weeks of the gestation or within the 72 hours of the delivery. Okay, if you are giving within 72 hours of the delivery or at the 28 week of the gestation, I told now this 28 week of the gestation is not recommended by the National Health Mission. Now the best answer is within 72 hours of the delivery we are giving. That is the very, very important thing. Just keep in your mind. Okay, so it prevents the formation of the antibodies in the mother. So it is preventing the formation of the antibody in the mother means it will not affect the second baby also. Okay, so very important. Please do consider. Here comes to the next question. What is the standard prophylactic dose of the RhoGAM injection which is giving to the Rh negative mother with Rh positive fetus? I told mother is N, that is the MN, and fetus is positive FP. Okay, so to remember, right? So in a Rh negative mother who is having the Rh positive fetus, so what is the dose of the RhoGAM injection? The dose of the RhoGAM injection is the 300 microgram will be the standard dose of the RhoGAM injection what we are injecting to a Rh negative mother with Rh positive fetus. Very important. Sir, if they are not giving in the microgram, they will give this one in the international unit. So please do remember 1500 international unit and the 300 microgram both are the same. So please do consider. Sir, what is the route of administration of the RhoGAM, sir? Intramuscular. Intramuscular is the route of administration of the RhoGAM, right? Sir, dose is 1500 international unit or the 300 microgram or the route is intramuscular. Please do remember this one. It is very important. If in case they are asking the question, in case of the I bar C bar O means in case of ectopic pregnancy or abortion or the molar pregnancy, what is the dose of RhoGAM injection? What is the dose of the RhoGAM injection? That is the 150 microgram what we can see injection RhoGAM we will give. Again the intramuscular we will give irrespective of the incompatibility. If the mother is negative and father is positive, just we will administer this one 150 microgram of the RhoGAM injection we will given in a case of the ectopic pregnancy, abortion or the molar pregnancy. Better this abortion or the ectopic pregnancy and molar pregnancy which are terminating less than 13 weeks. If these are terminating before the 13 weeks only, so your dose will be 15 microgram. Okay, so please do remember. If it is terminating before 13 week or early in the first trimester, the dose will be 50 microgram. And just they have not mentioned any week, just they are asking in case of the ectopic pregnancy, abortion and in the molar pregnancy, in order to prevent the Rh incompatibility in the next pregnancy, what is the dose of the RhoGAM injection? The dose of the RhoGAM injection is the 150 microgram. That is also we are giving intramuscular. So that is also we are giving within 72 hours of the after abortion or the ectopic pregnancy termination or the molar pregnancy termination. Okay, that is the very, very important. Please do consider in your mind. Okay, hope it is completely clear to every one of you, right? So here will be the next question. Indirect Coombs test done in which case? Beta, do remember indirect. We are doing IN in IN. Okay, that is in the incompatibility. We are doing. Okay, so what we are assessing? This is the red blood cell. Okay, against this red blood cell. Okay, any antibodies are freely floating in the blood or not? We are assessing. Against this our red blood cell, any antibody which are freely floating inside the blood or inside the serum, we are assessing. Okay, so indirectly we are assessing the antibody which is not attached to the RBC. That is the indirect Coombs test. In the direct Coombs test, what we will do? Okay, any antibody which is attached to the RBC directly. Okay, so any damaged antibody which is attached to the RBC. So this one we are assessing means the antibody which is directly attached to the RBC we are assessing means that is the a direct Coombs test. Okay, so direct Coombs test, where we are doing the direct Coombs test? Yes, fadafat do mention your answer in the comment box. Indirect Coombs test I told in the incompatibility or in the RH incompatibility we can say. Okay, so direct Coombs test, remember the HD Kumar Swami, that is in the D and H. Okay, so that is the in case of the hemolysis. In case of the hemolysis, we are doing the direct Coombs test, which is very important for your exam. Okay, so please do remember. This will be your exam question. Indirect Coombs test will be done in the RH incompatibility, and direct Coombs test will be done in case of the hemolysis or in case of the hemolytic anemia. Okay, hemolytic anemia, very, very important. Okay, so we are assessing the antibody which is attached directly to the RBC is the direct Coombs test, and we are assessing the antibody which is freely floating inside the serum is called as the indirect Coombs test. Hope these both are very much clear to every one of you. And here will be the next question. In HIV positive patient, what is the size of the induration which is considered as the positive tuberculin skin test? The question is in front of you all, so please do read the question carefully, completely, and try to give the best answer. In a HIV positive patient, what is the size of the induration is considered as the positive skin test? Option A, more than 5 mm, option B, more than 10 mm, option C, more than 15 mm, and option D, any induration we will consider as positive. What is the correct answer? Yes, I am waiting for your answer in the comment box. I want everybody's response. Yes, in HIV positive patient, what is size of induration is considered a positive tuberculin skin test? Option A, more than 5 mm, option B, more than 10 mm, option C, more than 15 mm, and option D, any indurations. Yes, well done, beta. Okay, so almost all you people given the correct answer. There is the more than 5 mm is enough to consider as the a positive test in a HIV positive patient. Why? Because in HIV, you know the full form of the HIV, this is human immunodeficient virus. So this virus is causing the or suppressing the immunity. Wherever there is in the low immunity, in the low immunity cases, okay, so if the induration which is coming more than 5 mm, it is enough to say it is the positive test. Okay, so very important, consider what are the conditions where will be immunosuppressed cases we have. That is the HIV positive patients or the immunosuppressive patient, and the patient who is on the steroid for the long term, or any post transplantation patient who is on the immunosuppression therapy. Okay, any post organ transplantation patient, organ transplanted patient. So these all patients are the patients who are in a low immunity states. Okay, so low immunity states means the induration which is coming more than 5 is enough to say it is on the positive tuberculin skin test. Okay, in case of the high risk individuals like we as a nurses or the healthcare providers, all healthcare providers like doctors, nurses, hospital staff, lab technicians. Okay, so this all hospital staff at the high risk for the tuberculosis infection. Why? Because we are daily exposing to the TB patients, especially the nursing officers and the lab technicians. Okay, so lab technicians, they will directly handle the sputum of the infected person, and we directly involved in the care of the patient. Okay, so we are having the highest risk. Okay, in the hospital staff and the children which is who is less than 5 years of the age. Okay, and others like high risk staff. So in these conditions, if it is coming more than 10 means that is the positive. The person who is not having any risk factors, so for that those person which is more than 15 is called as the positive. Okay, so that is the very important. Let's begin the some golden point chanting on the tuberculin skin test. It is important. When we need to read the tuberculin skin test, So after the injection, after 48 to 72 hours after injection, we need to read the tuberculin skin test. Okay, we are only measuring the induration, not the redness. Okay, beta, consider this is the a beautiful hand. Okay, and here we have the forearm. Okay, so this back portion we call as the dorsal portion of the forearm, and this front portion we call this one as the ventral portion of the forearm. So where we will inject the tuberculin skin, where we will inject the purified protein derivative, the PPD or the purified protein derivative, I will inject at the ventral portion of the forearm, because this is white in color and this is usually black in color. So in order to easily identify, I will inject that one in the white colored area. Okay, so just I am injecting the purified protein derivative here, you consider, right? So now this particular area is the tender, red and hard. Okay, so this is a tender, red and hard area. I call this one as the induration. Okay, because of this tender, hard and red area, so this surround area is somewhat become red in color. Okay, so you know, like surround wound, how the area will become red. So that is what we call as the erythema. Better in the tuberculin skin test, just we need to measure the induration. Means this particular part we need to measure, not the red area. Okay, so if you are measuring the red area, means it will usually comes more than 15 mm. So that is not gives the correct answer. Only the size of this induration should be measured. That is the hard, tender area only we need to, and the raised area. So that is only we need to measure here. So this induration only we need to measure, not the redness. Don't measure the redness. Just measure the. Okay, so just measure the. Don't measure the redness, just measure the induration. Okay, so that is a very important golden point you have to keep in your mind. Okay, so let's come to the interpretation. Already we have discussed it. So that is the more than or equal to 5 mm is considered as the positive in a patient that is positive for the HIV, that is the immunocompromised patients. Okay, and recently close contact with the active TB case. Okay, for them also we will consider the 5 mm is positive. That is the recently only close contact of the active TB patient. Okay, and the organ transplantation patient who is on the immunosuppression therapy, and the immunocompressed patients like a patient on the steroid and the chemotherapy. So these all patients, just the induration which is coming more than 5 mm or the equal to 5 mm, that's considered as the positive test. Okay, so very important in a if the induration which is coming more than or equal to 10 in a patient who is like recently immigrates from the high TB burden countries. Okay, and there is a country which is having the highest TB burden, from there the person is immigrating here. Okay, and IV drug abusers, very important, and the healthcare workers like nursing officers, hospital staffs, doctors and everyone. Okay, so we are high risk individuals. Okay, for us, if it is coming more than 10 mm or equal to 10 mm, that is considered as the positive, and the children less than 5 years with the risk factors also we will consider as the positive. Okay, and the people with the diabetes risk factors, the people are living with the risk factors like diabetes and chronic kidney diseases and the cancer. Okay, in these high risk patients also we will consider as the more than 10 mm is the positive. Okay, and in a healthy individual, okay, the healthy individuals with no any risk factors of risk factors. So for the healthy individuals, if it is coming more than 15 mm, then only we will consider this one as the positive. Otherwise, we will consider this one as the negative test. Okay, so hope this is clear to every one of you, right? So the next is here, the golden points on the tuberculin skin test. Better this tuberculin skin test, we also call this one as the Montex test, or we also call this one as in the Percute test. Don't get confused. If the examiner is giving the new name, don't get confused. Okay, the Montex test or the Percute test or the tuberculin skin test, all are three are same. Okay, so here this is based on the delayed type of the hypersensitivity reaction to the Mycobacterium tubercular bacteria. Okay, so which is based on the delayed type of the hypersensitivity reaction. Consider point. And what we are injecting here, we are injecting the purified protein derivative. Okay, we are injecting which route? We are injecting by the intradermally. Very important. Where we are injecting? We are injecting at the ventral portion of the forearm. Okay, so we are injecting at the ventral portion of the forearm. Very important. Okay, And what is the dose of the purified protein derivative? That is the 5 tuberculin units, we can say, or we can say in the tuberculin units, this is the 5 tuberculin units. In the ml, it is the 0.1 ml. Okay, so very important. 5 tuberculin units or the 0.1 ml we are injecting. And test we are reading after 48 hours to the 72 hours after the injection, we are reading the test. Okay, only induration we are measuring, not the redness. Very important. Patient had the recent BCG vaccine, means it will give a false positive tuberculin test result. And the patient is immunocompromised like HIV and all, the patient will give the false negative result. Okay, and this particular tuberculin skin test or the Montex test or the Percute test, it does not differentiate the latent TB or the active TB. It will say only the patient recently exposed to the tuberculosis or not, or the patient who is previously exposed for the tuberculosis or not. Tuberculin skin test is positive, means a patient previously he is exposed for the tuberculosis. Tuberculin skin test is negative, means the person is not exposed for the tuberculosis in his old life or in his previous life. Okay, very important. Please keep in your mind. And here will be the next question. Which of the following is secondary prevention strategy? But this question on the level of the prevention, that is the primordial, primary, secondary, tertiary. These four are very important for your exams. Okay, so please do consider which of the following is the secondary level of the prevention among the given options here. Yes, after the exams you have to just give the feedback on this number. I am writing the number. Okay, please take a screenshot or take a number. On this number, just you have to send the feedback how much the master nursing classes, crash course and test series will be helpful for you all. Okay, so that is especially a free crash course and especially the free test series what we have launched recently. And since from the last 10 days we are giving the free test, or that is on the all India level, how it actually helped you. Okay, so you have to send the, at least 1 line 2 line feedback on this particular number. Okay, that is the 8971949620. Okay, so this is only WhatsApp number. Just you are calling, means it will not get connect, so it will be your WhatsApp message you can do. Okay, so that is very important, right? So which of the following is the secondary prevention strategy? That is option E, pap smear for the cervical cancer screening. Yes, almost all people given the correct answer. And the option B is the counseling for the stroke patient, and option C is the vaccination program, and option D is the use of the seat belts in the vehicles. But so almost all you people given the correct answer. There is the secondary prevention, means secondary level of prevention, means what we are doing here in the secondary level of prevention. Yes, we are trying to early diagnose and the proper treatment we are trying here. How we will early diagnose? Early diagnose by the screening test. Okay, so pap smear is the screening test for the cervical cancer. Okay, so pap smear is the screening test for the cervical cancer. Okay, so here comes to the very important level of the prevention. That is the pap smear test. Okay, in the screening of the very important cervical cancer comes to the secondary level of the prevention. Okay, we are counseling to the stroke patient, means already a disease have been happened here. So now we are trying to reduce the disability and we are trying to rehabilitate the patient. Okay, counseling for the stroke patient goes to the tertiary level of the prevention. Okay, it will goes to the tertiary level of the prevention. Very important, right? So the vaccination program means here we are trying to specifically protect. We are trying to specifically protect against a specific infection. Okay, so specific protection, it will comes under the, yes, the specific protection will comes under the very important primary level of the prevention, right? Primary level of prevention. Okay, so very important. Please do remember, right? Similarly, using the seat belts in the vehicles or using the helmets during the riding is again we are specifically protecting against a risk factor, that is the road traffic accident. We are specifically protecting ourselves. So this is also using the seat belts and using the helmets also a part of the very important primary level of the prevention. Okay, so and the pap smear test is the secondary level of the prevention, and the counseling to stroke patient is the tertiary level of the prevention. Let's quickly revise with the examples. First, I will deal you with the definition, because the definition is itself very important for all the level of the preventions. But of primordial prevention, what we are doing in the primordial prevention, just we are trying to reduce the risk factors here. In the primordial prevention, what we are doing the reducing the risk factors is the primordial prevention. Okay, so we are taking the steps to destroy all the risk factors which may causes the impact on the health. Okay, so what are the examples will comes on the primordial prevention? Just we are taking the initiation towards the healthy food practices, yoga, exercise, okay, and policy makings in the particular our area, our like what we can say, in our colony we are making the good policies that the smoking is not allowed inside this particular area, selling the gutka, tambaku is not allowed this particular area. Okay, so smoking is not allowed near to the school area. So these are the, we are reducing the risk factors. Okay, so reducing the risk factors, making the policies, adapting to the exercise, yoga and healthy food practices, and early behavior modification, if anything, by the parents to the children. So that's all comes under the primordial prevention. Okay, these all comes under a primordial level of prevention. Very important, please do consider. Okay, so next we are reducing the risk factor, means that is the primordial level of the prevention. The second one is the primary prevention. In the primary prevention, the very important, again two things are there: health promotion and the specific protection. Okay, so what is the primary prevention? Now risk factor is there, but this is not how been happened yet. Okay, just we are taking the actions before the onset of the disease. Okay, now risk factor is here and the disease is here. Okay, after the risk factors only disease will come, right? So risk factors are existing and disease still not happened. We are taking the step before the onset of the disease. Okay, or we can say the action before the onset of the disease is the primary prevention. Okay, so primary preventions are the action before onset of the disease is the primary prevention. So here we will specifically protect the high risk individuals. Okay, so like this. So consider if the diarrhea is the most common cause for the rotavirus is the most common cause for the diarrhea in the children's. Okay, so we are protecting against the diarrhea specifically by giving the rotavirus vaccine, right? Very important. And pneumonia is the most common in the children's by the pneumococcal vaccines, pneumococcal what we can Streptococcus pneumoniae bacteria. Okay, so in order to reduce the risk of the pneumonia, we are giving the PCV, that is the pneumococcal vaccine. Okay, polysaccharide pneumococcal vaccines we are giving, means we are specifically protecting against some disease conditions. Okay, so vaccination is comes under the specific protection. This is the primary level of the prevention. Okay, this is the vaccination comes under the primary level of the prevention. And the prophylactic antibiotic, like in the surgical safety checklist before giving the like skin incision or the before giving induction of the anesthesia only. Okay, we will give the prophylactic antibiotics. Why we are giving? Whether to treat or prevent? Yes, we are giving it to prevent. Okay, we are giving the antibiotic as the prophylactic antibiotic to prevent the disease, means we are taking the action before the onset of the disease. Okay, so prophylactic antibiotics also it will comes under the primary level of the prevention. Very, very important. The primary level of the prevention, that is the prophylactic antibiotic we are giving to prevent the onset of the infection. Next means we are taking the initiation or we are taking the action before the onset of the disease. That is the specific protection. The prophylactic antibiotic comes here. Okay, and wearing the seat belt and the helmet also, which comes under the a specific protection. Okay, that's again the primary level of the prevention. Okay, so the health education will come under the a primary level of the prevention by the like health promotion strategies we are implementing at the area. So that will be a very important primary level of the prevention. Okay, so the secondary level of the prevention. Now the first one is the risk factor. So risk factors we are reducing means the primordial, and the second one is the disease. Before the onset of the disease, we are taking the actions, means that is the primary. And now disease have been happened, so we are reducing the disability. Okay, so the disease we are not treating means it will go to the as a complications. Okay, so now before onset of the complications, we are reducing the complications and we are reducing the severity of the disease and we are reducing the progress of the disease. Okay, so now the disease happened, this disease may get land into the complication. Before the onset of the complication, before it progress into the severity, we are reducing the complication and the severity, means that is the secondary level of the prevention. Okay, the action taken to reduce the impact of the disease or the action taken to reduce the complication of the disease or the action taken to halt the progress of the disease. Okay, so action taken to halt the progress of the disease means to stop the progress of the disease from the mild to the severity. Okay, so we are taking the actions to reduce the or to halt the progress of the disease. This comes under the secondary level of the prevention. Very important definition for your exams. Okay, so in the tertiary level of the prevention, just we are improving the quality of the life by disability limitation and by the rehabilitation. Okay, so here the disease complication have been happened, and due to the complication the person is going into the disability, and a person is going into a loss of its all the functional and anatomical structure. Here we are trying to recover and bringing the patient back to the normal situation. Okay, so that is the improving the quality of the life, and we are trying to rehabilitate, and we are trying to reduce the disability. So that is comes under the tertiary level of the prevention. All this level of the prevention and its definition is very important. Okay, so next I told in the secondary level of the prevention. So we have to what we have to do? We have to, like, disease have been happened, so that is the early we need to diagnose it and early we need to treat this. The early detection and the prompt treatments will comes under the secondary level of the prevention. Okay, so that is the very important. In the primary level of the prevention, what we are doing? We are doing the specific protection. Okay, so in the secondary level of the prevention, we are doing the early detection by the screening test like pap smear test, mammography for the breast cancer, and breast self-examination. So these are all the screening tests which comes under the secondary level of the prevention. Okay, and the proper treatment means if the cancer have been happened means we are giving the chemotherapy and we are using the therapeutic antibiotic drugs. Okay, so in the primary we are using the antibiotic drug as a prophylactic to prevent the disease. Now here we are using the antibiotic to treat the disease. Okay, so we want the disease to get cure in the early phase. Okay, so that is the secondary level of the prevention. This is the secondary level of prevention. Very important. Please do consider for your exam. Okay, so hope it is clear to everyone of you, right? So next comes the rehabilitation or the restoring the lost function. So that is what we call as the, like, a prosthesis we are installing, like a head of the femur is fractured and the femur prosthesis we are replacing, and the heart wall is damaged, so we are introducing the artificial heart wall. Okay, so that is the like a tertiary level of the prevention. Okay, that is what becomes as in the rehabilitation. Okay, this is the tertiary level of prevention. Okay, so very important. Here comes to the next question. Hope the level of prevention is very much clear to every one of you, and the definitely question will strike in your exam on the tertiary level of the prevention. So on the secondary level of the prevention, primary level of the prevention. Okay, so lots of the time there is in the question have been asked on the examples, and this time there is chance of asking the question on the definition. So that is the reason repeatedly I have explained the definitions of the each and every level of the prevention. Okay, so next comes to the questions on the HIV. So in the next 15 minutes I want to revise the entire HIV content for you all. Okay, because this is important for you all. Okay, according to the NACO guidelines, how many clinical stages are there in the HIV infection? So students, according to the CD4 count also there is in the clinical stages are there in the HIV, but we want the guidelines according to the NACO. Okay, we don't want the clinical stages according to the CD4 count. Okay, why? Because the examiner will ask the NACO guidelines clinical stages. Okay, so how many clinical stages are there in the HIV infections according to the NACO guidelines? So total there are the 4 clinical stages are there, and almost all you people given the correct answer. There is the 4 clinical stages are there in the HIV according to the National AIDS Control Organization guidelines. Okay, so NACO full form is the National AIDS Control Organization. So very important, please do remember. Okay, so here will be the all 4 stages. The question will come. The patient is experiencing the persistent generalized lymphadenopathy. Okay, and other than that there is no any weight loss, there is no any oral ulcers, and there is no any symptoms. The patient will be in the asymptomatic stage, only the generalized lymphadenopathy is happening. So what is this stage of the HIV? Yes, only the lymphadenopathy is happening without any symptoms. So that is the stage of HIV is the asymptomatic phase or the mild stage or the stage 1. Okay, so very important. And the next question will comes. The patient is experiencing the chronic diarrhea more than 1 month continuously 1 month is happened, but still the diarrhea is not controlling. And when we will see a blood, okay, that is the severe bacterial infection will be there, okay, and the prolonged experience of the fever will also will be there, and the weight loss have been happened more than 10% of the body. Okay, so now previously the patient was 100 kg, now his weight is 89 kg, means more than 10 kg, means more than 10% of the weight is getting lost. Okay, so which stage is this thing? Yes, that is the stage of the third stage. Like this question will comes in your exam, right? So very important. Do remember the golden words and what to remember in every stage and how to identify the answer. I will tell you. If the examiner mentioning the patient is having the seborrheic dermatitis, very important. Seborrheic dermatitis and the fungal nail infection and a seborrheic dermatitis and moderate weight loss. That is the less than 10% of the weight loss. So this is the stage 2. Very important. Keep in your mind. Less than 10% of the weight loss, seborrheic dermatitis and the fungal nail infection. So that is the mild symptomatic HIV or the HIV stage 2 will be your answer. Asymptomatic only generalized lymphadenopathy, that is the stage 1 will be your answer. If in case the weight loss is happening more than 10%, and the chronic diarrhea more than 1 month, and the patient is having severe bacterial infections, prolonged fever, yes, along with that the oral candidates and the pulmonary TB risk. Okay, especially two things you have to remember. One is severe weight loss more than 10% and the chronic diarrhea more than 1 month. So this indicates the advanced symptom of the HIV or the stage 3 of the HIV. This question will strike in your exam. Please do remember. Okay. So next one. The patient is experiencing the Kaposi sarcoma and esophageal candidiasis and the extrapulmonary TB, HIV wasting syndrome and pneumocystic zerowicky pneumonia. So these are stages of the AIDS stage or the severe stages of the HIV. Better, please do remember. Okay, so stage 1 of the HIV we will not call as the AIDS. Stage 2 also we will not call as the AIDS. Stage 3 also we will not call as the AIDS. When the AIDS HIV it will comes into the stage 4, then only we will call this one as the AIDS. Okay, so from stage 1 to the stage 4, if the person wants to come, means this takes at least 10 to 15 years. Very important, please do remember. Okay, so after 10 to 15 years only HIV will get converts into the AIDS. Okay, so initial stage of the HIV infection we will not call that one as AIDS. So that one we call the stage 1 of the HIV, stage 2 of the HIV, stage 3 of the HIV based on the clinical symptoms, which is the very important one. Okay, so please do remember. Hope it is clear to everyone. Yes, now try to mention your answer. Okay, so I'm asking the question, don't watch at the this one, just listen and say which stage of HIV is this. The patient is having the chronic diarrhea more than 1 month. Don't look at the mobile, just look at me, look at my eyes. Okay, so the patient is having the chronic diarrhea more than 1 month and the patient is having the severe weight loss more than 10% of his body, and the oral candidiasis is there, not esophageal candidiasis. Oral candidiasis is there and the severe bacterial infection is there. So mention. Now just directly go to the comment box and mention which stage of HIV is this. More than 10% of the weight loss, more than 1 month chronic diarrhea, and the oral candidiasis, and the severe bacterial infection. Very good, very good. I am very proud of you about your memory. Just remember this one till tomorrow. That's it. Okay, so that's the stage 3 of the infection. And comes to the second scenario. The patient who is diagnosed as in the HIV positive, now he is having the seborrheic dermatitis, fungal infection of the nail, and the moderate weight loss less than 10% of the body weight. Yes, the patient is in which stage of the HIV? The patient is in which stage of the HIV? Very nice of you all. That is the second stage of the HIV. Well done. Okay, and the patient who is having the pneumocystic zerowicky infection of the lung, the most common cause of the pneumonia in the AIDS patient or the HIV positive patients, that is the pneumocystic zerowicky infection, and HIV wasting syndrome is the full body of the patient is lean, thin and cachexic. Okay, all the fat of the body have been destroyed, only bones are clearly visible. So that is what you call the cachexic body. Okay, so cachexia or the HIV wasting syndrome, pneumocystic pneumonia infection, and the Kaposi sarcoma, esophageal candidiasis, and the extrapulmonary TB, and the these are the symptoms are there, means that is the stage of the AIDS, or that we call as in the fourth stage of the HIV. So this will be your very important question. It means strikes in your exam. Okay, so please do remember the stages of the HIV. Next, the question will be here. What drug is given to the HIV exposed infant for prophylaxis under the NACO guidelines? Under the NACO guidelines, that is the National AIDS Control Organization guidelines. So which of the following prophylactic drug we need to give to the baby who exposed to the HIV positive mother? Okay, what drug is given to the HIV exposed infant for the prophylaxis under the NACO guidelines? Yes. So what is your answer? We have the in option, that is the tenofovir, judovidin, nevirapine, and the efavirenz. So what is the answer? Yes, I'm waiting for your answer in the comment box. I want everybody's correct answer in the comment box. And there is a situation where we need to give the judovidin and the nevirapine both, and there is a situation where we will give the only syrup nevirapine. Okay, so to the baby. So I will explain the both situation with a clear concept so that you can choose very easily. You can choose the correct answer, and only you can choose the correct answer very easily, because I am making it such a very easy concept for you all in the today's session. Okay, so please try to give the best answer for this one. Yes, almost all you people given the C as a correct answer, and you people will definitely see this question in the tomorrow's exam. So please do remember that is the nevirapine goes to the correct answer. So NACO recommends, okay, NACO recommends that is to give the nevirapine to the HIV exposed infant. Okay, if the mother is HIV positive, there is a highest risk of the transmission of the HIV from the mother to the baby during the birth. Okay, so during the birth, not antenatal period. Yes, it may be in the antenatal period, but during the birth is the highest chance. Okay, so when is the risk of the transmission is highest? Yes, in the antenatal, interpartum, or the postpartum. Hence, yes, during the interpartum period only there is the highest risk of the transmission of the HIV from the mother to the baby. Okay, so the nevirapine is the drug we are preventing the mother to a baby transmission of the HIV. Very important. Okay, sir, how and where and what drug we need to give? How we have to prevent mother to child transmission of the HIV? So this is the very important. Mother to child transmission of the HIV is the very important. How we need to prevent that one is the very important. If the baby is exposed to the HIV positive mother, consider now the mother is HIV positive and the baby is exposed to the HIV positive mother. So assess the risk of the transmission from the mother to the baby. Sir, how we need to assess, sir? Yes, but how to check means just you have to check the viral load in the mother. Okay, so what you have to do? You have to check the viral load in the mother. Okay, so you have to take the mother blood sample and you have to send to the lab. Okay, when the lab report comes, if the viral load is less than 1000 copies per ml, so there is the low risk of the transmission from the mother to the baby. If in case in the reports, in the viral load reports, it is more than 1000 copies per ml, there is the highest risk of the transmission from the mother to the baby. So very important, keep in your mind. So in case of the low risk, means the viral load report is telling that less than 1000 copies per ml of the HIV or viral load is there. Okay, so that is what you call as the low risk. In the case of the low risk condition, just we will give the nevirapine syrup for the duration of the 6 week. Okay, so that is 1 ml of the nevirapine syrup for the duration of the 6 week we will give here. If in case the viral load report is saying that the more than 1000 copies per ml of the viral load is there, so that is what you call the high risk of the transmission from the mother to the baby. Okay, so in this situation, if you want to continue with the exclusive breastfeeding, that time you have to give the judovidin plus nevirapine for the duration of the 12 week. Okay, and you don't want to continue with the breastfeeding, so you want to continue with only replacement feeding. Okay, just judovidin plus nevirapine for the duration of the 6 week we need to give here. Okay, this is the very important concept. In the low risk, nevirapine only. In the high risk, you want to continue with the breastfeeding, that is the judovidin plus nevirapine for the 12 weeks. And if you want to replace the breastfeeding and you want to give with the other feeding other than the breastfeeding, so that is the Jodavudin plus nevirapine will be the answer. Sir, what NACO recommends for the breastfeeding in the HIV positive mother? Beta, now the mother is HIV positive, mother is positive for the HIV. Okay, so whether this mother can able to feed the baby? Yes, this mother can able to feed the baby. Okay, so very important, the concept of the breastfeeding in the HIV positive mother and his infants. Okay, so please do remember, I told till the 6th week we are giving the nevirapine. Why? Because till the 6th week we are doing the any test, means in the baby it will won't comes positive or negative, or it may comes the false positive or the false negative. Okay, so please do consider. After the 6th week we are doing the HIV test in the child. So now the child is positive. What we have to do? We have to do the breastfeeding for the duration of the 2 years. Why, sir? Why? Because already child is positive for the HIV. Okay, so now you are stopping the breastfeeding. Again, it will increase the risk of the infection, because the breastfeeding, which is having the lots of the good nutrients, lots of the good immunity. Okay, so that will protect the baby from the other infections. And already child is HIV positive, so you can't do anything now. So just go with the breastfeeding for the duration of the 2 years. Okay, so exclusive breastfeeding for the 6 months, and after the 6 months, okay, along with the weaning, you can feed the baby till the 2 years. That is the very important. After the 6 week, if the HIV child means the child is comes as a HIV negative, that time just breastfeed for the duration of the 1 year. Okay, why? Because we want to reduce the transmission. Okay, it will decrease the risk factor. In the HIV negative mother, the breastfeeding will be given for the duration of the 1 year, and in the HIV positive child, we will give the breastfeeding for the duration of the 2 year. Very important for you all. Okay, so yes, now the concept is clear on the breastfeeding. So what we have to do about vaccination in the HIV positive child, sir? Whether the vaccination are contraindicated or whether we need to give, sir? Beta, NACO says no any contraindication is there for the vaccines. All the vaccines as per the schedule we need to give. But some live vaccines in this particular situation, if in case the CD4 count is less than 200, the CD4 count is less than 200, and the relative CD4 is less than 15%, and HIV symptoms are positive. So in these situations only live vaccines are contraindicated. In this situation, live vaccines are contraindicated. When the live vaccines are contraindicated, if the CD4 less than 200 and the CD4 relative CD4 count is less than 15%, okay, and the very important, the HIV symptoms are positive, so then only live vaccines are contraindicated. Very important. Consider the situation where the live vaccines contraindicated. So this is the criteria where the live vaccines is contraindicated. Please do remember. Okay, so hope it is clear. Comes to the next point of the very important point. Okay, so that is the, I told HIV and TB are the co-infections. Okay, so that is the reason whenever we will found any patient which is positive for the TB, we will screen for the HIV. Okay, whenever we will found the patient which is positive for the HIV, we will screen for the TB. Why? Because the most common opportunistic infection in the HIV is the TB. Most strongest associated opportunistic infection in the HIV is the Kaposi sarcoma. The most strongest associated and the most dangerous infection, or the cancerous conditions in the HIV positive patient is the Kaposi sarcoma, and the most common opportunistic infection is the TB. That is the reason all the HIV patients we will screen for the TB. Okay, so all the HIV patients just we are trying to screen for the TB, right? And all the TB patients we are trying to screen for the HIV. Okay, so please do remember this one. If in case both TB and HIV both the positive in the patient, what to do now? Beta, just you have to start the treatment for the TB first. That is the anti-tubercular therapy we will start first. Then we will give the 2 week of the gap and we will start the antiretroviral therapy. Very important. Okay, so in all the cases of the TB plus HIV positive, both are the positive. So we will start the HT first, then 2 week gap we will start the ART. Very important. Except in the TB meningitis. In the TB meningitis have been happened. Okay, in the TB meningitis, we need to maintain the 4 week gap. Okay, for the start ATT, that is the anti-tubercular therapy, and maintain the 4 week gap, and after that start the antiretroviral therapy. Okay, so in the TB meningitis, how much gap between the ATT and ART? So there is the 4-week gap will be there. Very, very important. Please do remember. Okay, so hope it is clear to every one of you, right? So here comes to the next question. That is the NACO targets. Beta, old targets what we have studied is the 90 percentage, 90 percentage, 90 percentage, 90 percentage. So some states have achieved this target. So those states who achieved the 90 percentage targets, for those states now NACO have given the new targets. So that is they should achieve the 95 percentage of the diagnosis, 95% of the good treatment, 95% of the viral load suppression, and the 95% of the good health and quality of the life achievement. Okay, so few states in the India have achieved this particular target. For these states now the NACO have given the new target, that is to achieve the 95% of all the HIV cases. Among the all HIV cases, 95% we need to diagnose. Okay, so among the all 95%, at least 95% we need to treat properly. Among the all the treatments, so 95% we need to run the viral suppression to all the patients. And among these all patients who is taking the treatment, among these all patients, at least 95% patients should lead a good health or the quality life. Very important. And NACO says we need to start the antiretroviral therapy immediately without a CD4 count ratio. Okay, start the antiretroviral therapy irrespective of the CD4 count, whether the CD4 count may be 1,000 or whether CD4 count may be 200. If the patient found HIV positive, start the antiretroviral therapy. This is the statement and the target which is given by the NACO. Okay, so the antiretroviral therapy is not depend on the CD4 count, whether it may be 1,000, whether it may be less than 200. Yes, we need to start the treatment for the HIV immediately. This is the very important. Please do consider. Okay, so the next point of the discussion here, screening and diagnosis of the HIV. The question will come where we will do the screening and diagnosis of the HIV in the ICTC center. What is the ICTC center? That is the integrated counseling and testing center. Students, the full form of the ICTC, there is highest chance of asking in the exam. What is the ICTC? It is in the center which is located in the like all the AIMS hospitals also, all the ESIC hospitals also, and in the all the taluka health hospitals, district health hospitals, and all the CHC. Wherever there is a healthcare facility is there, there will be a ICTC center will be there. Very important. In this ICTC center, what we are doing the counseling and testing of the HIV positive HIV patients or the suspected HIV cases. So the full form of the ICTC is the integrated, means we have combined counseling and testing. Okay, so that is what you call as the ICTC or the integrated counseling and testing center for the HIV. Very important. Please do remember. Okay, here we are doing the three very important tests. That is the ERS. E stands there is the ELISA. The most sensitive test for the HIV is the ELISA. And the first test what we have to do in the HIV is the ELISA. The first investigation or the first test is the ELISA, and the most sensitive test is the ELISA. ELISA gives the 99 percentile of the sensitivity to the HIV. Very, very important. The most sensitive HIV test is the ELISA, and first test to be done in the patient suspected with HIV is the ELISA. Along with that, in the ICTC center, we are giving the R, that is the rapid test, and the spot test also we are doing. Sir, whether any one we can do or the all we can do. Better, NACO says perform all the test. Okay, NACO test, perform all three tests. Very, very important. Please do remember. Okay, so this is the screening and diagnosis. So confirmatory test for the HIV. Please do remember. The confirmatory test for the HIV is the Western blot test. The direct question will strike in your exam. What is the confirmatory test for HIV? Confirmatory test for HIV is the Western blot test. Specific antibody detection we are doing in this test against the HIV virus. Against the HIV virus, so we are doing the specific antibody detection. So that is what you call as the Western blot test. Very, very important. Please do remember. Right? So if the examiner asking the gold standard test for the HIV is the HIV RNA. The gold standard test for the HIV is the HIV RNA detection is the gold standard test. Okay, please do remember, very important, right? The confirmatory test is the Western blot. The gold standard test is the HIV RNA, and the initial test and the most sensitive test is the ELISA in the HIV. Very important. The first test in the HIV is the ELISA. Very important question. Okay, so the next is here. Now, just we want to assess how the prognosis or how the progress of the HIV is happening. The test to assess the progress of the HIV, the test to assess the progress of the HIV, which test we have to do? The CD4 count we have to check. Why? Because the HIV virus, the human immunodeficiency virus, the primarily affect which cell? The human immunodeficiency virus, the primarily it will affect the CD4 count or the CD4 cell or the cluster differentiating type 4 cells. Very, very important, right? So which test we will assess, we are using to assess the prognosis of the HIV, that is the CD4 count. And now we have started the antiretroviral therapy. Okay, just I want to assess the effectiveness of this particular antiretroviral therapy. So the test to check the antiretroviral therapy effectiveness is the viral load test. That is by the P24 antigen assay. That is the viral load test we need to do. So this viral load test is the early test to get positive. Even the patient is in the window period. In the window period only the P24 antigen assay will come positive. Okay, so this is the reason early test to get come positive in the HIV is the P24 antigen assay. So that will help us to detect the viral load, and that will help us to detect whether the antiretroviral therapy what we are giving is effective or not. Hope it is clear to every one of you, right? So here comes to the next question. The most common type of the HIV in India. Which type of the HIV is common in the India? So that is the HIV-1 is the most common type of the HIV which is common in the India. But in the HIV-1 we have the again groups. That is the group of the M, N, O, P. The 4 groups we have. Okay. So among this N, so again this N we are having the 4 subgroup. Okay. That is the A, B, C, D, E, F. Okay. So among this, which all are the common means? Remember this most common is the most common. Means HIV-1, in the HIV-1 which group is common? That is the M type is common. Okay. So in the M type, which type is most common? That is the C type is most common. So please do remember. Please do remember. HIV-1, which group is common? In the HIV-1, the M group is most common. M group is most common. Okay. And in the M group, which subgroup is most common? In the M group, the C subgroup is most common. So please do remember. Okay. So which type of the HIV is common in the HIV? HIV-1 is most common in the HIV. Okay. So we have the 2 types of the HIV. There is the 2 forms or the 2 types of the HIV. There is the HIV-1 and the HIV-2. Okay. So this HIV-1 and HIV-2. In this one, HIV-1 is most common in the India, most virulent or the most dangerous. Okay. Seen all over the country. I told it is the most virulent and it requires only 10 to 15 years to get converts into the HIV into the AIDS. Okay. So it takes 10 to 15 years for the showing the symptoms, and it will take some 10 to 15 years to convert HIV into the AIDS. Okay. So the type 2 HIV or the HIV type 2, which is less virulent. Okay. Which is less virulent and which will be seen in the African countries. I told it is the less virulent, so it requires the more year to get show the symptoms. Okay. It requires 15 to 20 years to get show the symptoms. So the difference between the HIV-1 and HIV-2 is, I hope it is clear. So this was your CRE question. Okay. So in the CRE exam, the directly asked question, the difference between the HIV-1 and HIV-2. Hope it is clear to every one of you. Okay. So it will be very important, right? So here comes to the next question. What is the window period? Yes, what is the window period? Window period is, yes, at time of the infection or the time of the entry of the HIV virus inside the body to the formation and detection of the first antibody. Formation and detection of the first antibody in the blood against the HIV. Okay. So this is what we call as in the window period. This particular time gap between the time of the infection to the detection of the first antibody against the HIV. So this is what we call as the window period. This is the window period. Very important. And this is highly infective period for the HIV. Why? Because here the HIV infection has happened, but there is no any antibody against the HIV. and there is a high load of the virus will be there, but low antibodies against the HIV. So this is the highly viral load without antibody period. So that is the reason the highly infective period of the HIV is the window period. And what is the normal window period duration? That is the 2 to 12 week will be the normal window period duration. Please do remember. Okay. Hope it is clear on the window period. Window period is the time gap between the time of the infection to the detection of the first antibody in the blood. So that is what we call as the window period. Okay, window period is the highly infective period because we don't have any antibody to fight against the HIV infection, because here still we have not detected the first antibody. When the first antibody will detect, so that is the window period will complete. Okay, so that is the reason the highly viral loaded and without antibody period is the window period, and the high infective period of the HIV is the window period, and the time gap between the infection to the detection of the first antibody in the blood against the HIV virus is the window period, and the normal duration of the window period is the 2 to 12 weeks. Okay, so this is the very important, just keep in your mind. Okay, so the next is here. So what is the normal CD4 count we have? So normal CD4 count we have is the 800 to the 1200 ml per microliter is the normal CD4 count what we have in our body. Okay, so what is the normal CD4 count we have? So that is the 800 to the 1200 cells per microliter is the normal CD4 count what we have. Okay, so that is the when we will say it is on the Yates case, when the CD4 counts goes less than 200 cells per microliter, then only we will call this one as the Yates case. Okay, better if the CD4 is less than 500, less than 400, we will not call that one as the Yates. We call that one as the HIV. Whenever the CD4 count is less than 200 cells per microliter, then only we will call this one as the last stage of the HIV, that is the AIDS. Okay, AIDS is the final stage of the HIV. Please do remember, right? So this is the very important for your exam. This is the very important for your exam. Okay, so hope it is clear to every one of you, right? So here comes to the next question. Yes, the most common cause of the pneumonia in HIV positive patient. Most common cause of the pneumonia in HIV positive patient. The multiple time asked question in your exam, that is the pneumocystic 0VC or the pneumocystic carinii. The both are same. Okay, so one fungus, both name. Okay, so this is the opportunistic infection which happens or which causes the pneumonia in the AIDS patient or the HIV positive patient. That is what you call as in the pneumocystic carinii or the pneumocystic 0VC. The most common cause of pneumonia in AIDS patient or HIV positive patient is the pneumocystic 0VC or the pneumocystic carinii. So this will be the very important. This will be the very important. Okay, so examiner's favorite question. When it will happens? It happens in a last stage of the HIV when the CD4 count will be less than 200, or in the last stage of the HIV in a stage of the AIDS. So the pneumonia will happens, that is the opportunistic infection in the HIV, which is by the pneumocystic 0VC or pneumocystic carinii fungal infection. It is the very important. Okay, so not only it is important, it is the very important point. Okay, so please do remember. Then comes to the most common cause of the diarrhea in the HIV positive patient. Most common cause of the diarrhea in the HIV positive patient. Again, the very important question. Beta, in which stage the diarrhea will be there? The severe uncontrolled diarrhea more than, or the chronic diarrhea more than 1 month, that is in the stage 3 of the HIV. Okay, so here the chronic diarrhea more than 1 month will be there. The most common cause of the diarrhea in HIV positive patient is the Cryptosporidium is your answer. So please do remember for next 1 more days, it will be helpful. Okay, so hope it is clear to every one of you. So next question comes here. The cause of the Kaposi sarcoma in a HIV positive patient. What is the causative organism of the Kaposi sarcoma in the HIV positive patient? That is the human herpes virus number 8 will be our cause of the Kaposi sarcoma in a HIV positive patient. Next comes to the cause of the retinitis in the HIV is the cytomegalovirus will be the cause of the retinitis, the inflammation of the inner layer of the eye, that is the retina. The cause of the retinitis in the HIV positive patient is the cytomegalovirus. Hope it is clear to every one of you all, right? So next updates on the HIV, right? Better previously we were studying the ART, that is the antiretroviral therapy. Now we have the HAART, that is the heart therapy. Okay, so that is the heart means here is the again ART stands as the same, that is the antiretroviral therapy. HA stands H is the highly, A is the active, so that is the highly active antiretroviral therapy is the full form of the heart therapy. The question have been asked in your exam, what is the full form of the heart therapy? That is the highly active antiretroviral therapy is the full form of the heart therapy. In this one, we are giving the post-exposure prophylaxis of the tenofovir, lamivudine, and the new added drug called as the dolutegravir. What is that one? Dolutegravir. Okay, the dolutegravir plus lamivudine and tenofovir we are giving as a fixed dose combination. So that is the one tablet we are giving for the duration of the 28 days in the post exposure prophylaxis cases. Okay, so very important, please do remember. Okay, so the next question is here, the post exposure prophylaxis in HIV. The best time of administration will be the within 2 hours. The best time of administration of the post exposure prophylaxis in the HIV is the within 2 hours, very important. And when we need to start this one, we need to start this one within the 48 hours. Okay, so we will give for the duration of the 1 month. Better if the examiner is asking the question, the best time of starting the post exposure prophylaxis is within the 2 hours. The maximum time is we need to start this one at least within 48 hours. Okay, above more than 48 hours you are giving, after 48 hours you are giving means that is not going to that much effective. Okay, so please do remember, right? So here will be the next question is there. The questions will start on the fixed questions on the research, that is the research study designs. Okay, so why I have kept this all the golden topics last means these are the topics which you people have the highest chance of getting forget. So I am telling this all things just one day before the exam means you can definitely remember for the tomorrow and you will definitely choose the answer. So if you are choosing the answer, my purpose is clear. Okay, and you are all like you are all the work, you are all the dedication, and you are all the efforts also going to be come out as a successful result. Okay, so that is the very important. Okay, what type of study design is most appropriate for the studying the rare diseases? Beta, so if you want to study the rare diseases, okay, which type of the study design we have to do here? Okay, in which study design we are studying the rare diseases? We are studying the rare diseases in a case control study design, very important, and almost all people given the correct answer. Beta, studying of the rare diseases which comes under the case control study. So what we will do in the case control study, let me explain the concept of the case control study, so you will be coming to know that. Okay, so remember in the case control study what we are doing, this is the case means the deceased person and one is the control group. Okay, so case control study, there are the two groups we have, there are the two groups. Okay, one group is the case, or we can say a deceased person or the person with any kind of the diseases. Another group is the control group, another group is the control group. Okay, so we will hold the case or we will hold the deceased person and we will ask him for his risk factors what all he have had in his previous life. For example, we have the patient with the liver cirrhosis. We have the patient with the cirrhosis of the liver or the cancer of the liver you consider. Okay, so in this cancer of the liver patient or the liver cirrhosis patient, we will ask the risk factor. So that is, did he have the alcohol in his previous life? Did he have the smoking in his previous life? Or did he had the hepatitis C virus infection in his previous life? Or did he had any kind of the load pull work on the liver previous lives? We will ask. So we are holding the disease and we are asking for the risk factor, means we are going back. But what happens? So you just see in the normal process of the disease, first the risk factor will be there. After the risk factor, the disease will come. Okay, so the disease will come. After the disease, the complication will come. Okay, after the complication, the disability will come. The disability will come. Right? So in the case control study, what we are doing, we are holding the case or we are holding the deceased person and we are going back. Okay, so we are going back and we are asking the what all are the risk factors he is having in his life. So we are going back means what we call this one, we are going back means we call this one as the retrospective. I am going forward, I am moving forward in the prospective, I am going back is the retrospective. Okay, so that is the reason this case control study we also call this one as in the retrospective study. So this study we will use for studying the rare diseases. Okay, so this retrospective study or the case control study is the study we are using to study the rare diseases. Please do remember. Okay, so this is the thing what actually happens here. Okay, so very, very important. Now what we are doing here, we are holding the case and we are asking for the risk factors. So this one what we call as in the a case control study or the retrospective study. Students, now the person is a old age, he is having the liver cirrhosis because since from the last 10 years he was drinking the alcohol. So we are asking the person to recall all the old risk factors and tell. So now patient have forgotten some risk factors. Okay, so here which bias happens in the case control study means the recall bias will happen here. Okay, recall bias will be faced by the patient or will be faced by the researcher here in this particular case control study. Very, very important. Okay, similarly also for control group we will hold. Okay, in the control group there is non-diseased person. Okay, again we will ask for the risk factors previously. Okay, he was not having any alcoholic history, smoking history, or hepatitis C vaccine, hepatitis C infection history, means in the future there is no risk of the cirrhosis and the liver cancer. Okay, so this is what we are very importantly need to consider in mind. Okay, so 3 golden points, that is which bias happens in the case control study, recall bias, and which study we also call as the retrospective study, that is the case control study. Okay, so very, very importantly what we will study in the case control study, we are studying the rare diseases in the case control study. Hope the concept is very much clear on the case control study. Okay, so the next question is here in front of you all, so please do read the question carefully and completely. Yes, a prospective study is also known as which of the following condition? Yes, for which study we will call this one as in the prospective study. Better, in the prospective study we also call the prospective study as the cohort study. Okay, so what we will do in this cohort study is, in the cohort study what we will do, again we will hold the 2 groups. Okay, one is the group which is having the risk factor. Okay, another group which is not having risk factor. Okay, so for this group which is having the risk factor, we will follow up for the duration of the 10 to 15 year we will follow up, and due to this risk factor any disease is happening or not, yes, we will check if the disease is happening, yes or no. So we are holding the person with risk factors and we are following the person for the duration of the 10 to 15 years, and after the 10 to 15 year follow up, so just we are seeing that whether the disease is happening or not in this person. If happening it is yes, if not happening it is no, right? So in the control group also similarly, a person without any risk factors, again we will follow up for the duration of the 10 to 15 years. Okay, so again we will see whether the disease is happening or not. Yes, so here we are doing the long follow up and we are moving from the risk factors towards the disease. From the risk factors towards the disease we are moving, means we are moving forward. So that is what you call as the prospective study or the cohort study. Okay, so very, very important. I told the process of the disease will happens like this. First risk factor will be there, after that disease will be there. So we are coming back disease to the risk factors, means that is the retrospective study, this is the case control study. Okay, and we are holding the risk factors and we are moving forward. So this is what you call as the prospective study or the very, very important cohort study. Okay, so that's the very, very important you have to keep in your mind, right? So hope it is clear to every one of you. So in this particular 10 to 15 year of the follow up, there is chance of the loss of the our research elements or the research data or the research participants, right? See, some employees we are considering who is working in one particular company, and we have taken that employees as our research, what we can say, samples. So now that particular employee is transferred from one particular area to another particular area. So he is leaving our group, or he is leaving our research participant. So we are losing that particular element of the our sample means. So in the process of the follow-up, we are leaving the, or we are losing the participants. We call that one as the attrition bias. What is that? That is the attrition bias. Okay. So let me solve the question on the attrition bias. Okay. So what is the term for the systemic loss of the participants in a prospective study due to the various factors such as the personal reason and health issues? Yes. So due to the personal reason or due to the health issues, we are losing the like participants from our study in the, especially during the cohort study, where we have to follow for the 10 to 15 years. Okay. So in this particular situation, there is highest chance of the attrition bias. Okay. We are losing the participants from the research division. We call that one as the attrition bias. So very, very important question for your exam. Okay. Here comes to the next question. Better. Now, in this particular cohort study, what happened? We are holding the patients with the risk factors, and we are following up him for the 10 to 15 years. So now this particular participants are the research sample. They know we are observing him. I am a researcher and you are a patient. Means you are a research component, or you are my research sample you consider, or you are my research participants you consider. You know that I am observing you. I am doing the follow-up of you. So that time you will manipulate your behavior. You will do some actions. Okay, so that the false manipulation of the behavior or the false actions when the participants will do when they comes to know that the researcher is observing them. So that is what you call as the Hawthorne effect. That is what you call as the Hawthorne effect. So what is the Hawthorne effect? What does the Hawthorne effect refers in a psychological or the sociological research? Yes, this is a very, very important. The tendency of the individual to modify their behavior when they are aware that they are being observed. Okay, so the patient or not the patient, the research participants, they know that they are being observing by the researcher. Okay, so that time they are having the manipulative behavior, they are changing their behavior. So that is what we call as the Hawthorne effect. The very, very important point, just keep in our mind. Okay, so next here comes to the question. Yes, which of the following can a cross-sectional study research will measure? Beta, this cross-sectional study research, we also call this one as in the snapshot research. Okay, so this is the entire community you consider. Among this entire community, the researcher will take just a mini sample, or we can say the snapshot from the entire society. Okay, and he will do the research. He will do all the old plus new cases assessment, and whatever the result will come, that result he will implement on the, or he will generalize in the entire community. So this research design, what you call as in the cross-sectional research design or the snapshot research design. What happening among a particular entire community, the research is taking only the selected part of the community. Okay, only selected part of the community have been taken. So that is what a snapshot of the entire community have been taken, and we are doing the research on this particular small community only. Okay, from the entire area we are doing the research in this only population, and whatever the result is coming, that one we are generalizing on the entire population of that particular community. So this is what we call as the cross-sectional study, or a study to assess the prevalence of the disease. Okay, so by using the cross-sectional study, what we are doing the prevalence of the disease assessment we are doing. So the research, the cross-sectional research, we also call this one as in the snapshot of the community. What we call this one is the snapshot of community. Beta, you are studying research from me in detail means you will become a good researcher in your entire nursing field. Okay, this is just sample I am showing to you people, right? So among these 4 research design, what we have studied now, that is the cross-sectional study as a snapshot study, and cohort study as the prospective study, case control study as a retrospective study, and one more, the very important study design what we have studied in the today's session. Among these 4 questions, one question will be definitely striking in your exam. Okay, so all the possible short which is coming in your exam, I am giving in this today's session. So I am today's session very free very easy, very normal, and very casually explaining, because I don't want to create any stress. Just I want to introduce some important points in your mind. Okay, so if I am in the hurry means you people will get land into the stress. Okay, so that is the reason I am teaching in this today's class very cool, composed, perfect way, so that you people are learning one thing means that may get utilized to you. Okay, so that is the main purpose of this class. Okay, so the next question is here. Yes, assertion and reason based questions. Match the following questions. Questions with a long stem. Whenever you will see in the exams, just try to be very happy, because you are the person who practiced all the assertion and reason based questions in the master nursing classes test series. Every day you have practiced the assertion and reason based questions. Every day you have practiced the match the following questions. Every day you practice the long stem questions, one liner questions, important questions. Okay, and all the necessary formats of the questions we have practiced in the master nursing classes, super 60 test series, and the Navagraha plan. Perfectly you people have been practiced. So whenever you will see this kind of the questions, try to give one smile in front of the computer, read the question and give the answer. Remember the Nagaraj sir there. Thank you, sir. Say that thank you, sir. Okay. Yes. So let's begin this one. Okay. So what happening here? In the assertion statement, what they have told, they're telling the delirium has the acute onset of the fluctuating the course. Yes, the delirium is the acute onset and which is variable in the course. It is not steady, it is not constant. Okay, so which is acute condition which is fluctuating in the nature. So the statement is correct, the assertion is correct. And the reason, delirium is often caused by the underlying medical illness or the drug toxicity. Yes, so this is acute condition which caused by some medical conditions or due to some drug toxicity. So that's the correct only. Okay, the reason also correct. Okay, so both option A and R are true here, right? R is the correct explanation for the A, so that is the correct answer goes to the option A here. Okay, so these kind of the questions also will be striking in your exam. Please be aware this one. Okay, let me quickly explain the difference between the delirium and the dementia. Okay, so beta, in the delirium, you remember what happened in the delirium. Remember, there is one eye, means this eye indicates this is the impairment in the cognition, impairment in cognitive or the impairment in the cognitive functions. And one more eye stands here as the impairment in the consciousness, impairment in the consciousness. So consciousness is impairing means it is not in the chronic condition. So consciousness will impair in the only acute situation. So delirium is the acute situation. Okay, so delirium is the acute situation. Okay, where it will not be steady. Okay, so the delirium will be fluctuating. So sudden there is a chance of the altered level of the consciousness, then it will comes to the normal, then altered level of the consciousness, it will comes to the normal. Okay, so fluctuation will be there in the delirium. Okay, similarly in the dementia, what happens in the dementia? Okay, there will be an impairment in the IMP. One is the intellectual problem, memory problem, and the personality problem will be there, and the cognitive disabilities will be there, but there is no any change in the consciousness in the dementia. Okay, so please do remember, in the dementia, no change in the consciousness, only cognition change. Okay, and no change in consciousness, no change in the consciousness. Very important, please do remember, no change in the consciousness, only cognition change, that is the dementia. And dementia is in the chronic organic brain disorder, it is in the chronic organic brain disorder, and delirium is the acute organic brain syndrome, or we can say the acute organic brain disorder, where organic brain disorder, that is the delirium. Okay, in the dementia it is the chronic organic brain syndrome or the chronic organic brain disorders. Okay, so let's me discuss all the golden points on the delirium and the dementia. Hope the chart is clearly visible. Okay, I told the delirium is the onset will be acute. Okay, suddenly it will happens within hours to days, but dementia is the gradual and it is the chronic. So that is the reason we call the delirium as the acute organic brain syndrome and the dementia as the chronic organic brain syndrome. Okay, very important, right? So a course of the delirium is the fluctuating, it is not steady, but the dementia is the steady. Okay, so duration it will be short term, it will be long term. The delirium is the reversible condition. Okay, so it will be often completely reversible if we are treating perfectly, that is the delirium, but the dementia is usually irreversible. Dementia is the irreversible, delirium is the reversible. Remember, the question will strike in the exam. Irreversible organic brain syndrome is the dementia. Reversible organic brain syndrome is the delirium. Okay, so attention is severely impaired and the consciousness is severely impaired in the delirium. Okay, so level of the consciousness impaired severely in the delirium, but then there is no change. There is no change or the clear until late stage. Okay, so until it goes to the last stage, there is a chance of altered consciousness, but the dementia will not have the any altered level of the consciousness in the early phases. Okay, so please do remember, dementia there is no change in the level of the consciousness. In the delirium there is the change in the level of the consciousness. Okay, so very important. The cause of the delirium, this is the acute cause only. That may be acute illnesses like infection of the brain, drug toxicity, metabolic imbalance, or the acid base imbalance which causes the delirium. Okay, so in the dementia, the neurodegenerative diseases like Alzheimer's disease, Lewy-bone dementia, okay, which will cause the dementia. Okay, so very important. I told the delirium is the acute condition, so there is in the emergency treatment is very much necessary, and the dementia not emergency treatment is required, but the long term therapy we need to give in the dementia. Very important. Please do remember the difference between the delirium and the dementia. Yes, so hope it is clear to every one of you, right? So in the question, just you have to mention what is the, in the assignment question, just you have to say what is the transference, what is the counter transference, what is the confabulation, the three words. Among these three words, one question will strike in your exam. Okay, so definitely believe me, what is the transference? Again from the psychiatry, what is the transference? Transference means the patient showing emotion towards primary health care provider or the nurse. Okay, so this is what you call the transference. If counter transference, in the counter transference, please do remember the nurse or the primary healthcare provider or the nurse showing emotions on patient. So this is what we call the counter transference. Okay, so remember the one more word, there is the confabulation. We will see in a organic brain disorders. Okay, there is the confabulation, severe changes in the memories. Okay, the filling the gap of the memory is the confabulation. Okay, filling gap of memory is the confabulation. Among these three words, one word is fixed in your exam. Transference, patient showing emotion towards the primary health care provider or the nurse is the transference. Counter transference, there is the primary health care provider or the nurse showing the emotion on the patient is the counter transference. Confabulation is the filling the gap of the memory is the confabulation. Okay, so I hope you people have been enjoyed the today's session, and I told this is the number, the mobile number what I given to you people. Okay, so just try to send your feedback after the exam. Okay, try to send the questions what have been came in the exam, so we will discuss that one in detail. Okay, try to remember the options also. Okay, so that will be helpful for us. Okay, so all the best for your exam preparation. Okay, so don't take stress now and don't study anything new now. Just whatever the thing you have studied till now, so that is the more than enough. Okay, so definitely from the today's class you are going to face at least 2 to 3 questions in the exams. Okay, believe in this one, and wishing you all the best. Nothing is impossible if you believe in yourself and go with the blessing of your parents and from your teachers. From my side, from my whole heart, I will pray in the God that a good result will be yours, and who all are worked hard and who all are worked for your destination, definitely you will people will get the success. All the best from the master nursing classes and your Pari master Mr. Nagraj sir. Okay, so thank you so much and wishing you all the very best and the good luck for your tomorrow's exam. Give the best shot and don't forget the master nursing classes after the exam. Thank you so much. We will meet after the prelims exam with a paper discussion, and we will continue for the mains exam as well. So hope that today's session was the very cool, calm, relaxed and enjoyable. Okay, so thank you so much for the watching the video till the end. Don't study anything new now, so just close your eyes, finish your and close your notebook. Okay, try to listen the music. Hare Om, Hare Krishna, Krishna Krishna, Hare Hare. Om Namah Shivaya. Jai Hind, Jai Bharat. We will meet again after the exam. Bye bye. Take care. All the best. Good luck.